What is a comorbidity? How do comorbidities impact treatment decisions?
Comorbidities are other health conditions, such as, more commonly, high blood pressure, high cholesterol, diabetes, heart disease, that patients have along with, dealing with their cancer diagnosis, in this case, multiple myeloma. The average age of diagnosis is in the mid-60s to late 60s, right? And so by that time, high blood pressure is very common. Diabetes is very prevalent. And because of the multiple myeloma, many patients end up having renal dysfunction. So renal kidney disease is a comorbidity that we encounter often. I would say these are the three big ones that we see.
How does diabetes impact myeloma treatments?
Because of their diabetes, we have to be mindful about if patients have long-standing diabetes that's not so well controlled, we have to be mindful about peripheral neuropathy because it impacts the choice of therapy we actually give patients. So, diabetes, we have to be mindful when it comes to peripheral neuropathy, but we also have to be mindful about how we dose steroids. Oftentimes, in a newly diagnosed multiple myeloma patient, when the disease burden is very high, that means there's a high plasma cell percentage in the bone marrow, their light chains are very high, or the M spike is very high. We want to hit it very hard, go aggressive, and if usually you're under 70 years of age, I utilize, at least in the first cycle, 40 milligrams weekly of dexamethasone, which is a hefty dose. And if you have a concurrent diabetes diagnosis, then you're going to have issues with blood sugars, essentially. And if I have time, that means I'm not in an urgent setting to start treatment right away. Oftentimes, we utilize the help of our diabetes specialist within the cancer center. So we have a dedicated nurse practitioner who helps us manage mostly diabetes in our patients. Or I will have them go to their primary endocrinologist or primary care in terms of guidance on or before or the days after their dexamethasone dosing. On how to take their insulin, how to increase their hypoglycemics, what sort of diet they should be taking around that time. So we're very, very mindful, often over the age of 70, because steroids are sometimes very, very hard to tolerate. I dropped the dose down to 20 milligrams, and so it's at least half. But even with that, I'm very mindful about the sugars.
How does heart disease impact myeloma management?
Heart disease can have a significant impact in the management of multiple myeloma patients. Many of the drugs that we give can or are associated with cardiac toxicity. In the case of carfilzomib, it's associated with raising your blood pressure, so hypertension. It can also cause systolic heart failure, or raise the pressure between your pulmonary vasculature that communicates with the heart, called pulmonary hypertension. So if there's already pre-existing conditions such as this, then we want to minimize further exposure to agents that will cause furder damage. We at UT Southwestern are very lucky because we have a very comprehensive cardiology program, and we have a cardio-oncology team and a CHF team that helps manage our amyloidosis patients. Cardio-oncologists, especially when we have patients who we have difficulty to control high blood pressure, or they have a pre-existing CAD, they've had a stent placed and we want to take them to stem cell transplant. Our cardio-oncology colleagues will see them right away, and they sort of will help us put them on goal-directed medical therapy for heart failure, to have their heart function improve if they have low, and they sort of just guide us along on how we treat. So I've actually utilized their help multiple times, actually.
How does renal dysfunction impact myeloma management?
So renal dysfunction, well, first thing you have to know is what is causing the renal dysfunction? Is it another comorbidity? Like, let's say they have diabetes-induced or hypertension-induced, CKD in the older patients? Or is it actually because they have the light chains that are so high that are sort of clogging up their renal tubules, called light chain cast nephropathy? So you have to understand the etiology, because if it's light chain cast nephropathy, you're going to be very aggressive, because reducing the light chain burden is actually going to help them recover their renal function faster. But once you sort of sort out this initial first 1 month or so of treatment, when patients do have light chain cast nephropathy, what is, daratumumab is used up front many times nowadays. That doesn't really require renal adjustment with renal function. Even Velcade does not. Dexamethasone does not. However, Revlimid does. So you have to adjust the dose based on the creatinine clearance, because the higher dose means that Revlimid will hang around longer, and then hence you can have more cytopenias. So you worry about toxicity when you're giving them a higher dose than they need based on their kidney function, actually. So we have, I often calculate that myself, or I will utilize the help of my pharmacist in reducing the dose, and that's what we do.
Do comorbidities influence fitness, frailty scoring?
When we make a decision on who's fit or frail, it's, although we don't always outline it psychologically in our heads, there's like a running list of what the patient has. How's their heart looking? Number one thing we look at, right? If they want to go to transplant especially, do they have good heart function? And if they don't, well, then I'm going to get them to see their cardiologist. And maybe I'm not going to be as aggressive about pursuing stem cell transplant right away. So comorbidities do impact our initial decision making and whether a person is fit or frail. And I think we have to take a step back and delineate, is the frailty because of their disease? Because there you want to be aggressive. Or is they were frail to begin with? So during my encounters with my newly diagnosed patients, I sit with them and I ask them, how were you doing before everything went south? What was your quality of life like? Were you walking? Were you active? Were you doing those? I think that gives me a big insight into their fitness. Many of the comorbidities, with the help of the consultants we can actually manage. I have, with the help of our cardio-onc team or infectious disease specialists or endocrinologists, we can get them through a lot of the comorbidities and get them to the more aggressive therapies. However, fitness and rehabilitation is actually, I consider that a very important part. So if I see that there's frailty because of disease, well, then you have to address the disease. And patients who have they were not active because they have a pain in their hip because there's a lesion there, or they have a pain in their spine and they're afraid to move. As the myeloma heals, they get better, they feel better, their mobility automatically improves actually. So they go from that frail from their disease to actually becoming fit. And I know that, I believe Tanya Wildis has done a lot of work in geriatric oncology, particularly relating to myeloma, about that. And I'm very big on cancer rehab. So we have a cancer rehab program over here. So my frail patients, which whether it's disease or underlying, I send them to our cancer rehab program for evaluation and then get them to physical therapy. And we set small goals. And I encourage walking, and the steroids have a side effect as well. Well, because they cause proximal muscle weakness. So I tell my patients to be active. So that physical fitness plays a big role, I believe.
What comorbidities are most prevalent in newly diagnosed myeloma?
Comorbidity is a chronic disease that is not myeloma, that you have besides your myeloma, you can say that. It could be chronic pulmonary lung disease, it can be congestive heart failure or diabetes, and other cancers as well. So this is comorbidity. I can tell you a little bit about what it is in Denmark, because I think that comorbidities varies from culture to culture. But what we do have, and we did a study again on the Danish quality database where we looked at newly diagnosed myeloma patients and comorbidity. And what was interesting was that 1 year preceding the diagnosis, there was an increase in comorbidities. And there is comorbidities like kidney failure, which is part of the myeloma disease, but also congestive heart failures, chronic pulmonary lung diseases, diabetes was there, and in total 40% of the patients had comorbidities at diagnosis. So that's a lot of patients with comorbidities as early in their myeloma history, because it also develops throughout their history due to treatment.
How do comorbidities impact treatment decisions?
You do modified treatment because you don't choose a drug that will give you neuropathy if you have neuropathy. And if you, for example, also have had a previous pulmonary embolism, then you're reluctant with the IMiDs. It can be done, but you have to be very careful. And I think that today, where you have so many treatment options, I mean, patients do better. Patients that have comorbidities, for example, chronic pulmonary diseases and heart diseases that are severe, they cannot go through a transplant. A transplant is still the first option for younger patients in Scandinavia. I know it's changing in US, but it's still what we do here. And then you have to treat them otherwise with the standard treatments that are available for us and modifying the treatment.